Hello, and welcome to today's webinar, The Role of Coordinated Care in Protecting Vulnerable Patients. Before we get started, I'd like to review a few housekeeping details. Today's webinar is being recorded, and an online archive of today's event will be available within 1 to 2 business days. If you have trouble seeing the slides at any time during the presentation, please press F5 to refresh your screen on a PC or Command R if you're using a Mac. You may ask a question at any time during the presentation by typing your question into the Q&A box located on the right side of your screen and pressing Enter. And finally, I'd like to remind you of AHIP's antitrust statement located in the link just below the slide viewer. We will, as always, comply with that statement. Among other things, the antitrust statement prohibits us from discussing competitively sensitive information. We're very fortunate to have with us today Drs. Christopher Dodd and Julian Perez. Dr. Dodd is the Chief Medical Officer at Mcara Health, where he leads the company's effort to scale its national network of home-based advanced primary care medical practices. Prior to joining Mcara Health, Dr. Dodd served in a variety of executive and senior leadership roles, including value-based medical groups and federally qualified health centers. Dr. Perez is a physician leader at CMAR Community Health Centers in Washington State. He's an advocate for universal health care for all and supports primary care physicians and the community health center model as the instrument for achieving this goal. At this time, I would like to turn the floor over to Dr. Dodd.
All right, thank you so much, Megan. Hello to all. Thank you so much to everyone for taking the time to listen in on this conversation for your engagement. We're really excited to have this conversation and look forward to your questions. So thank you, Megan, for the introductions again. And just briefly wanted to share a little bit more information about Mcara Health, the national medical group that I work for. We don't have bricks and mortar, and we're really focused on meeting patients where they're at, wherever they call home, whether that's a homelessness encampment, a skilled nursing facility, or a home in any community. Our company was born about 2 decades ago with a foundation of advanced analytics. And over time, this advanced analytics and other intellectual property has been what has allowed us to be successful in value-based payment models, where we're ultimately taking total cost of care risk for the populations we care for. I am incredibly humbled and excited to have Julian with us today, and just wanted to give him the opportunity to briefly introduce himself, and then we'll jump into the conversation.
Thanks, Dr. Dodd. Good morning, everybody. My name is Dr. Julian Perez. I am a physician with CMAR Community Health Centers in the primary care family medicine clinical area. I also have a specialty in sports medicine and ultrasonography for musculoskeletal diagnostics and procedures. And I've worked at CMAR for 15 years. CMAR is a community health center, federally qualified community health center. We'll get into a little bit more of the details of that later. I think it's important to know that also my parents were migrant workers. They were Mexican migrant workers. And so, I come from a background and a lived experience that makes serving this community particularly important to me. So I share the mission of the organization that I work in, and I think that's a big reason why I love what I do, and I bring a lot of passion to my work.
Thank you, Julian. All right, so the theme of our conversation is really about the role of coordinated care in protecting vulnerable patients. And I wanted to share briefly a study that came out in the American Journal of Managed Care a few months back that demonstrated that 40% of Medicare beneficiaries were designated as having the opposite of coordinated care, right? In fact, highly fragmented care. And to me, what stood out in that article was that on average, this population has about 13 ambulatory visits a year. And that population saw 7 different practitioners during that period. So you can imagine 13 visits in a year with 7 different practitioners. and the most frequent provider of care saw those patients for only 3 of those 13 visits. So really, this got us thinking that, you know, this Medicare study was just a canary in the coal mine. In healthcare, you know, we're always talking about the North Star being delivering, you know, the quadruple aim for populations and doing it in a highly coordinated way. But the reality is this study, our own lived experience and the lived experience of our family and friends demonstrates that we're headed in the opposite direction. And so in that context, the other thing I wanted to share is when I think about the US healthcare delivery system, I think often about a Jackson Pollock painting. And you can remember sort of Jackson Pollock as this painter that pursued the ink blot technique. And so you can picture a canvas and what you see is all sorts of different colors. It doesn't really look organized. It's chaotic. And there's a lot of white space everywhere. I actually think that's a perfect representation of the US healthcare delivery system. And what we've been seeing lately is the proliferation of point solutions, right? Companies are out there saying, hey, I'll take this one area of white space and we'll add value there. Or we'll focus on one disease or one organ and we'll add value there. And I think for primary care physicians like Julian and I, while we see value in those point solutions, what we also experience and our patients experience is increasing fragmentation, which really decreases their experience. And we know from the payer perspective, it really increases the administrative complexity to manage the care of your membership. And at the end of the day, even though these point solutions are touting lower cost of care, the reality is that healthcare costs keep going up. So the reality is, again, that we're in a pretty tough spot. But what's so exciting to me, and I know is exciting to Julian and many of you, is that there are some real outstanding examples of care models that are really delivering on the promise of coordinated high quality care. And for many of us, you know, we may not immediately consider the US safety net system as a source of that guiding light. But the reality is that CMAR as a federally qualified health center is a perfect example. And so we're going to really learn, you know, with Julian, through Julian, about what makes CMAR unique, how it's evolved, to the point where it is really successfully delivering coordinated care for vulnerable populations. So let's launch into some questions, Julian. The first one that I wanted to ask was, tell us a little bit about just sort of high level CMAR's populations that you serve.
Sure. So I'll answer that with a story, tell you a little bit about how CMAR came to be. Mid-70s, a lot of migrant workers from Mexico working in both Eastern and Western Washington state, going up and down what we call the Western Migrant Stream. And these folks were free to cross the border back and forth during the growing seasons, but they had no insurance. They had no, you know, security in really anything, including housing. And so, you know, they just survived and did the work, got paid cash, sent it home. So those remunerations back home is one of the main economic drivers of most of the Latin American countries, and traditionally Mexico being the longest country that we have experience with in this United States of America. But you know, they really didn't have a place to go get health care. And so we had people who were dying of tuberculosis. We had people who were dying of bacterial pneumonias at very early ages, like in their mid 40s and 50s, and that was unacceptable. It's just that no one was paying attention to it because, you know, they weren't really a counted population. And so along with the civil rights era, a number of experiments sprung up all over the country, and in Washington State, CMAR Community Health Centers was one of those. And we just rode on the coattails of people like Jack Geiger, who, Dr. Dowd, you know well. He established, you know, community health centers in urban Boston and rural Mississippi. And so that model caught fire, and we realized that we could get federal funding to do good quality work to take care of people that were in vulnerable situations who had abysmal health outcomes. And not only to affect those, but also to study them and to make sure that we defined those in a public health lens and continued to keep track of those throughout the years. So CMAR opened a single clinic in South Seattle back in the mid-'70s, and that has grown now to over 140 brick and mortar sites. We serve like 300,000 patients. We do medical, dental, behavioral health as the core trio of the services that community health centers provide. But that has expanded so much more. We have coordination of services, we have population health management, we have labs, X-ray, radio stations. We even do affordable housing now, because we understand that our patients' health depends so much more on just what we do inside the walls of our clinic. We want to get outside of the clinic more and be creative in how we care for our populations. And so, the assets that we bring to our work, number one is trust. We have worked very hard to build a reputation of trust among our patients. And that is something that we protect very carefully, because if patients don't trust you, they're not going to come to you, and you'll be ineffective. The second thing is that we come from the community. My own lived experience is an example, but most of my staff are Latino. They speak Spanish. They grew up migrating and picking crops, so they understand the patients, and they really can relate to them, and that furthers that trust that we have with our clients and our patients. And the last thing is those brick and mortar sites. Access is our primary mission. People need access to care, and so if we are in nearly every community that is underserved, then they're always going to have a place to go, to get care. When we first, I think I'll just leave it there, Chris, and we can move on and continue to cover some more with your next question.
No, that's a great overview. And then just if any of the members of the audience are wondering about sort of lines of business, population that you're focused on,
sure.
In that perspective, it's primarily a Medicaid population, but you are also focused on, you do care for patients that are on Medicare, dual eligible folks, but the primary focus is on managed Medicaid, and it's really in the spirit of family medicine across the lifespan.
That's
Great.
true. Yeah, we've evolved in that well with our payer mix and our age. Yeah, young, healthy people, and we're getting more and more.
Yeah, that was a wonderful overview, and historical context, from the birth of the community health center movement and CMAR over the last number of decades. One of the things that we know is so important to delivering healthcare is the payment model, and we know it's specifically a key driver of delivering really high quality, sort of the best brand of primary care. So can you share a little bit, Julian, about how your contractual arrangements have evolved over time with your payer partners, and how that's been a critical lever to support this comprehensive coordinated care model that you're currently delivering?
Yeah, no problem. So when we first opened, it was pretty much a young working population of men, and essentially we operated as an urgent care. We also brought in, basic public health actions like vaccination. And over the years, we started to evolve more into a full spectrum primary care and preventive health organization, because those workers would bring their wives and their kids. And so we had to start providing prenatal care and well child checks and pap smears and mammograms and things like this. And there was a time, I would call it like the golden era of, immigrant life in the United States, right before, September 2011, when the towers came down with the terrorist attack in New York City. Our patients were so happy. They were so thriving. Classic family was going to be a man in his, late 20s or 30s, and a wife maybe with a kid or two, and she was pregnant with a third on the way. And they just came to clinic. They were so happy and so healthy, and they were able to come and go to their countries, every year, and they were able to work hard and give to the economy. And we were so happy to take care of them. And then as soon as those towers came down, borders tightened up, immigrants were deported, and folks were forced to overstay their visas and continue to, again, participate in that number two economic driver of their countries, which is remunerations, from the United States, work back home. And so we had people who began to grow old with us now. We have people who were typically in their 20s and 30s, now they're into their 40s and 50s, and they're developing chronic diseases. Lay on top of that chronic stress from being in a situation where they're effectively incarcerated inside our borders, unable to go home and see their families, a lot of depression, a lot of, substance abuse. And so more and more, we had to develop behavioral health and substance abuse services for these people. We started measuring a lot more diabetes, a lot more obesity, a lot more dyslipidemia. And so we had to develop chronic disease models that we picked up from Group Health in Seattle as laid out by the chronic disease model of care. And so we learned from that chronic disease model that you need coordination. You need patient education. You need patient navigation to certain specialty appointments. You need coordination of care. You need people to follow the stats, collect data, analyze the data, and figure out how we improve our algorithms and our protocols. And so we evolved over the years until finally federal government said, hey, guess what? We're not going to do paper anymore. We're going to move to computers. So as soon as we went to electronic health records, that data collection, that data analysis got so much better. And we were able to know what we didn't know, right? It's good when you know what you don't know. It's bad when you don't know what you don't know. And so everybody in the United States, as soon as they started collecting data with electronic health records, we now knew what we didn't know. And we were able to become much more laser focused in these areas. And so with a federally qualified health center, it's not a lot of drop-in programs and drop-in diseases. We really want to slowly raise that bar of health care and quality metrics across the board. And we can do that effectively as federally qualified health centers because we have a grant that pays us Medicare rates for seeing Medicaid patients. And since we're a 501c3 not-for-profit, at the end of the year, all the uncompensated care that we render, we can then deduct from our taxes. And so it doesn't hurt us too bad by the end of the year. We struggle during the year because, sometimes we're bleeding money taking care of people who cannot pay, except for the, small fees we collect up front at the desk. But at the end of the year, we basically are back to zero. And so it allows us to serve people who cannot pay, who are uninsured or underinsured. And it allows us to continue to grow and serve the communities that need us, which are always more need, a tidal wave of need. And so now you got the passage of the Affordable Care Act, and that then redefines who can qualify for Medicaid. And it used to be 100% of poverty and below. Now it's 133% of poverty and below. Then we're able to sign up a lot more of our patients, 40% more of our patients now are insurable people. And so that gives us a big injection in the arm for being able to afford new services for them. And a lot of that was coordination of care, because we realize when people come to you with chronic diseases, they have to come in regularly. They need reminder calls. We need translation services. They need transportation. They need patient navigation to their referral areas for specialty care. And then now lay on top of that, so you have ACA, you have Medicaid expansion. And then with the Medicaid expansion, we now have about 6 payers in the state of Washington who manage those Medicaid dollars. And what happens is the insurance commissioner gives them a defined set of benefits, a defined set of services that every one of those insurance carriers has to provide to the patients. And then on top of that, they can compete. They can compete and see who does it best. And so CMAR signed up with all of them. And we still continue to take insurance from all those carriers. But they started to say, okay, you know what? We want to be smarter in how we spend our dollars. How would you guys like to explore a value-based reimbursement system with us? And we said, yeah, we think we know about that. Tell us more about that. And so they explained what it was. And we said, oh, that's just like prenatal care. And so for years, we've been doing prenatal care where the state of Washington gives us a lump sum, I think it's like $8,000 or $9,000, to take care of women from the point that they enter into our system with a positive pregnancy test until 6 weeks postpartum when we do their postpartum visit with a birth control application. And if a woman comes in at 39 weeks and drops a baby in the lobby, or if she comes in at 4.5 weeks and it takes 50 visits to get her to the end of the goal line, it's the same point. It's the same price that we're paid. But we're able to do it well because we coordinate with local hospital partners. We follow hospital protocols that are evidence-based and spelled out by very smart people that we have input with and we meet with every quarter. We have an OB coordinator who is a very important person in our clinic that touches base with every one of those patients every trimester of their pregnancy. We have a maternity support services, which includes a social worker, a community health worker that goes out to the homes and visits them if they need to, infant case management so that when that child is born, it doesn't fall through the cracks and miss its well visits and its vaccinations, make sure it doesn't end up at somebody's house for 40 days and ended up with kernicterus because the bilirubin went up and no one knew about it. And then we have a nurse. So when women get complicated, we can refer them to the MSS nurse, and they can start talking to them about gestational diabetes, cholestasis of pregnancy. And then we also, of course, we have women and infant children, which is the nutrition services for women and their children under 5 years of age. And we are the #1 provider of WIC services in the entire state of Washington because of those 140 BRIC sites that we own and operate. So that model, the reason that model is successful, we not only had adequate outcomes, we had as good or better outcomes than everyone else in the state of Washington using capitated payment rates, spending those dollars as wisely, as smartly as we knew how, because we know our population. We figured, okay, if you want to give us capitated contracts for Medicaid patients, I think we can do that because we know how to do this already. And so we did. And now every one of those Medicaid contracts is a capitated contract. They're all value-based. And what we have to do is define our populations based on how medically complicated they are. They're very socially complicated as well. We do explain that in the ICD-10 codes. But at the current moment, we are only being reimbursed for medical complexity. And so we work really hard to tell the story in the ICD-10 codes. We send those to the Medicaid payers every year. They give us a ratio or a quotient, basically, of how much money they'll give us per patient. And then we get that lump sum at the beginning of the year, and we spend it how we see fit. At the end of the year, if we come out ahead, we split the savings with the payer. If we come out behind, too bad. We miscalculated.
Lovely. Yeah. So that, Julian, it's really a remarkable story. And I love the fact that you wove together all the points that you did from this, how your population's lived experience was changing in the U.S. and how that, forced a transition from delivering primarily acute care to both acute and chronic care. The expansion of your population who became insured through the Affordable Care Act and the Medicaid expansion here in the state of Washington, as has occurred in many other states across the country. And then the need to develop a very coordinated system that was built on the bedrock of sort of this early capitated or value-based approach to caring for pregnant women. So super, super remarkable. And I think, I know when I have conversations with so many people out there in the community who are within healthcare or not, many don't recognize that there are federally qualified health centers like yours who are well down the risk continuum and are succeeding because of your roots and because of the innovation and focus on evolving your care delivery model. So it's really such a special story, and you just want to create that model for everyone. So let me shift a little bit more to an opportunity for you to talk again about some of the innovation that you and the team have done at CMAR. I want you to talk a little bit about yourself here. You mentioned when you introduced yourself that you also practice sports medicine, and after completing your family medicine training a decade later or so, went back and did additional training. So tell us a little bit about how you and the leadership team at CMAR recognize the ability to bring more services underneath the continuum of this advanced primary care umbrella.
Right. So I think, we're lucky to have a CEO that was a finance, trained career. And he understands that, you can have a not-for-profit umbrella financially as a business model, but you can put for-profit businesses underneath that. You can put other not-for-profit businesses underneath that umbrella, but it's all, everybody's related, everybody works together. The other thing that we understand is that our patients trust us, right? And they trust the places that we exist, which is our brick and mortar sites. And so access to care is the mission. Trust is the way that we facilitate the care. And everybody who comes to us knows where we are. They are familiar with where we are. Think about a person who's been in a refugee camp for 20 years. and now they come and relocate in King County, Washington State. They're not used to walking more than a mile in any direction. And so if they need dialysis or if they need specialty care with a rheumatologist, to catch 2 buses and go downtown in this enormous city with these great big skyscrapers that they've never seen anything that tall in their life, and to have to navigate through escalators and elevators and language barriers to get to a specialist, for them is inconceivable. And so the more we can do under our roof, the better. And so with that philosophy, that's why we have lab and x-ray. That's why we have dental. That's why we have pharmacies in our clinics. And with specialty care, that's always been a real thorn in our side, trying to get patients, not only get them there physically, but also get the insurances to pay for those, or get specialists to take Medicaid patients. And that's been a real drag. So there was about 7 years into my career here as a primary care doctor, and we had the recession, the Great Recession, 2007 to 2009, 2010. And I had so many patients come to me with very simple musculoskeletal, subacute conditions, that I knew that if we get them to physical therapy, or if we get them the proper care, that they would be able to get back to work and feed their kids. And if they didn't, they would turn into chronic cases. They would lose their jobs, lose their homes, and their kids would not eat. And we saw that over and over and over. It was very frustrating. And so one day I was invited to apply for a musculoskeletal sports medicine fellowship. And I decided to do that because I knew that the information we would learn would be transferable to our population. Our population is a working class group of people who earn their money with their bodies. And when the bodies break down, they can't pay the rent. And so I went for a year, came back, and we opened up a great big gym, for rehabilitation. We have 8 consultation rooms for sports medicine, musculoskeletal consultations. We brought in technology to use ultrasound as a diagnostic tool, effectively not replacing, but really lowering how many MRIs we need to order for our patients. In-house X-ray, and a lot of procedural expertise as well. And so that was the first dive into specialty care under our roof. And it worked so well that the leadership decided that we needed to expand this to other things. And so, cardiology came on board next, optometry, rheumatology, we have dermatology, nephrology, endocrinology. These are specialties that we always had a hard time getting patients into, or that we had high volume. And so the key is this: since we're a federally qualified health center, we get paid $200 a patient. That's still pretty good. And so we don't actually have to bill those patients as specialty codes. We bill them as primary care codes under a primary care roof, but it's specialty care. And so we've been able to expand and meet the demand and the medical need of our patients, and have specialty, right across the hallway. It's been really great.
Incredible, right? What a great story. And I think, just to me, what's so remarkable about it is how, again, this innovation and this evolution of the care model, it started with you listening to your patients, right? And understanding the needs of the population, right? And saying, what more can we do? And I think this is, for us, I think one of the primary, objectives of our conversation is really to emphasize that the more we can invest in primary care, and the more we can, as primary care medical groups, bring more services under our umbrella that we deliver directly, and where we don't deliver them directly, we're the ones that are quarterbacking the coordination of care to partners, right? And doing that, as Julian has been sharing, in an incredibly coordinated way. So thank you, Julian, for sharing that. And then, I think maybe one more question, and then excited to open up to audience questions. But tell us a little bit about, how CMAR has thought about the community health worker, right? We know that the community health worker has figured prominent outside of the United States for decades, as the United Nations and the World Health Organization has called to deliver primary health care for all. And the CHW was an incredibly important human resource to overcome all sorts of barriers and bottlenecks that people face around the world to living their healthiest life possible. So I know CMAR has learned from that, but tell us, a little bit about how CMAR thinks about the the CHW model from within this large sort of bricks and mortar footprint that you described?
Sure. So as the world has, changed in, the level of peace and prosperity that was available when you and I were children, now we have a world that's fairly unstable. We have a lot of water stress. We have a lot of climate stress. We have a lot of economic stress, and we get more and more refugees coming to our country. And so CMAR used to be a clinic that served people of Spanish and English language, abilities, and that was it. At this point, we have about 50 languages spoken among our patients. And so that really calls to us to have to up our game and figure out how we best serve people from multiple ethnicities, multiple countries. One way, some of those languages are indigenous languages from Mexico and Central America. The people of the Maya diaspora, they speak Mam, they speak Mixteco. We have people from the Purepecha region of Michoacan, Mexico. They speak Tarasco. Some of them speak Spanish, but not all of them. And so in our most agricultural areas that we serve, one of those being Skagit County in Western Washington, where they grow a lot of berries. They have quite a few people of that diaspora that are working there. And we had trouble taking good care of them because we weren't able to communicate. And so what one of our staff did was she wrote a grant that was earmarked to our federally qualified health center, major grant. And that gave us, like $250,000 per year in perpetuity with cost of what we call it with an inflationary, increases annually. That's the gold standard, right? Nobody can ask for anything better than that. And that sustains a group of community health workers that constantly do outreach to the communities, make sure that they bring their kids in for well-child checks, make sure the women know how to get prenatal care, make sure that they come in for their vaccinations. And they were tremendously effective in making sure that the migrant worker communities got vaccinated for COVID during the pandemic. You talk about canaries in the coal mine, these agricultural workers, and we define that not just as people, working with plant-based agriculture, but you have horticulture with the slaughterhouses and the raising of beef. We have timber and wood and plant raising and selling. That's also considered migrant work, agricultural work. Those populations were the most at risk and heaviest hit with COVID because they had no protections. They had no masks that were provided by their employers. They had no time off. They had no spacing. The best thing that they had, which was helpful, was a lot of airflow in their environments where they worked. But they got hit pretty hard. So having community health workers that could help explain to them what the disease was, very basic stuff like what's a virus, what's a microbe, how does something airborne get into your system and make you sick. A lot of that had to be done. A lot of that groundwork had to be laid, and we were able to get good traction with those communities because we had trust, right? We had language abilities, and we had community health workers that already developed relationships with them. Very quickly, they were saying, yeah, get me the vaccine. I want to keep working, because work is really the number one priority among our patients. They don't want to stop working. They have to pay the bills. They have to send money home. So that was a pretty successful project. That was a grant written about 10 or 12 years ago, and it's still going now. We do have other examples of community health workers. For example, in the maternity support services, we have the community health worker that goes out to the homes of our pregnant patients and will check on them if they're not able to come into their visits. We do have programs that we participate with through the county public health systems. One was an asthma study, about 5 years, where we figured out how best to serve patients who were failing in their asthma control by sending community health workers out to their homes. That was very successful. And then we had another project where we work with women who needed mammograms, going out and getting them come into the clinic. We have mobile mammogram units that come every month to our clinics, just making sure that if we had somebody that went and knocked on the door and explained to them what mammograms were and how important that was for their families, if that would improve rates of mammograms. And it actually doubled. It doubled the rates of the mammograms among our patients. So we know community health workers are effective. They do improve our chronic disease and our preventive health statistics. And we'd be very excited to get more involved in that.
Awesome. Okay. Yeah, no, thank you for sharing. And I know that, both you and I have a special love for that role and the huge impact that it can have. And, I'm proud of the fact that both of our medical groups recognize that and are, undertaking efforts to scale the community health worker role where it can make the most impact. So amazing. So let's turn to some questions. Francis, thank you for your question. So one of the things, Julian, that Francis sort of picked up on was, what were aware of, right? Which is that people in general, patients in the healthcare delivery system, but particularly those who are vulnerable and face social barriers, have a really hard time accessing specialty care, right? And paying for it. And so CMAR has absolutely undertaken, a strategy to bring increasing amounts of specialty care under your umbrella, which certainly, improves access, improves patient experience, improves quality, and then also allows you as a value-based provider, right, that takes risk on total cost of care to reduce specialty spend. So she highlighted that, and then she wanted to ask you to speak a little bit more about, Julian, there are a lot of cases with patients where they have wounds that aren't healing from oral antibiotics, and they may necessitate, an infusion. There are people that are living with heart failure or COPD that are on the, having an exacerbation and are really close to necessitating inpatient admission, or even already are meeting criteria. How are you and your team at CMAR sort of undertaking, efforts to, diagnose early and prevent those admissions by delivering more care, within your centers, or even in outside of your centers in the home?
Right. Yeah. So absolutely. Before we had really strong coordination of care and data analysis and the ability to get a hold of patients, quickly, we had a lot of admissions for these types of problems. I remember, wow, winters were just like all diabetic ulcers and IV drug use abscesses that we had to get drained, and cellulitis and sepsis. Like, that was just tremendous in the winter. And in holiday time was always like CHF exacerbations from Thanksgiving dinner. And then COPD, we had a ton of COPD admissions during the summer when people are out smoking with their buddies. But there's been some really good things that have happened in Washington State. You can't smoke in public anymore. It's against the law. So that was huge, to get COPD under control. Thank God we don't have a lot of smokers in our population. We have a lot of people that come from Mexico and Central America, and they're just not big smokers. But with our folks that are American-born, European ancestry populations who grew up with the Marlboro Man, right? They are still having a lot of trouble kicking that habit. We have health educators in-house, free of charge, 1 hour, to help coach people to stop smoking. We have all kinds of medications on our formularies for nicotine replacement therapy. And we have chronic care coordinators that work in our clinics. And so let's say a clinic maybe has 3 or 4 wings. Every wing will have a provider. The provider has an MA, and there's a care coordinator that works with that provider. So we huddle for a half hour in the morning. We take a look at all the patients, and our electronic health record is really good. It actually gives us a quotient to tell us how complicated somebody is and who we really need to focus in on for their chronic disease management. And so if we take a look and see that they're smoking, the first thing I do is I drop down a diagnosis for that, make sure I alert the health educator that he or she's going to want to visit with this person. And then we do the ask, advise, assist, and connect mantra for all our smoking patients. We've had good success in getting those down. If we have patients who are delicate patients medically, we actually, I still take call at the hospital. I admit patients, I catch babies, I work in the outpatient setting. And so I think that's another part of the secret sauce for CMAR, is that we have continuity with our patients. We see them in the clinic, we see them in the hospital, we see them post-hospitalization. And we have some programs that are state grant funded for coordination coming out of the hospital to CMAR. That's called, I don't remember the name of it, but it's essentially connecting patients. There are gold standards for Medicare patients. You have to get a follow-up visit within, I think, 6 days or 7 days or 5 days. And so they follow all those best practices and make sure those patients are sitting in front of us after their hospitalization with a discharge summary. But to keep them from happening again, we have the chronic disease model. So we see them every 3 months. If they don't show up, we have at least 3 different physicians in the clinic that are going to call them up and say, hey, you missed your appointment. Let's get you rescheduled. It's really important that we do preventive care. We have electronic health records. We can send people their medications electronically, refill those all the time. We have people answering the phone who are laser focused on medication refills, because that's a huge reason people decompensate, Chris. They don't have their medications on time. They can't get someone to refill those. Gosh, there's so many tools. I wouldn't call it redundant, but we just have so many layers to make sure that people don't fall through the cracks. So both human resources, electronic resources, communication resources. We can call, we can video conference, we can do MyChart, which is an phone app based way for people to get a hold of us. And so people just choose the way that they communicate the best. And then we make sure that, through language capabilities that we have, both in human resources, again, and with translation services, that we don't let people fall through the cracks. Very few of our patients are getting admitted nowadays for decompensated chronic disease. Most of the patients now are COVID, pregnancy, RSV in the kids, influenza, pneumonia, surgical issues. I did a consult on a surgical patient the other day. So definitely not a lot of chronic disease decompensation admissions anymore.
That's wonderful to hear. So I think the punchline there is, the ability to double down on coordinated care that brings as much focus to prevention, right, as it does to treatment, is the
Correct.
best way to keep people healthy home and out of the hospital. So thanks for running through all those examples. We have another question, and I think I can
getting them insured. Because if somebody has a way to pay, they're going to
exactly.
They won't show up until they literally need to be in the hospital, and so we work really hard to get people insured.
Yeah, absolutely. Yeah, and I know we have a lot of members of health plans and payers in the audience today, and thank you for all of the support and partnership that you get to medical groups like ours to get people insured. So another question came in around, sort of just this recognition that in this world where we have so many of these point solutions coming at us, and this is spoken from the payer perspective, it's hard, right? You're playing a lot of defense. We've got a lot of companies that are touting tremendous results, but the companies are just recently formed. They're small pilot studies. They're certainly not working with populations as large as CMARS, for example, 300,000 people. And so the audience member is asking, what advice do you have, for plans who want to work to transition more of their membership to medical groups like CMARS? And I think the quick answer, or I'll make a few comments, Julian, and then let you fill in. But from the payer perspective, I think understanding who within your network is high performing, right? And I think Julian has gave us a really great opportunity to understand, what are the assets and capabilities that primary care medical groups need to have to be able to deliver the quadruple aim for those populations. And I think partnering with them to improve their ability to get those outcomes is a great path forward. And then over time, I think working particularly within the managed Medicaid population where membership can be assigned, is to preferentially, lead members toward medical groups as such. So I think that's one approach. And then, as payers look at their entire population across lines of business, there are always going to be, 5 to 20%, depending on the line of business, of patients that, even with access to amazing primary care medical groups like CMARS, are still going to fall through the cracks for one reason or another. And the ability to partner with medical groups like ours to go to them rather than sort of wait for patients to come to us is another great avenue to deliver on population health, again, for that sort of persistently high cost, rising risk population that for one reason or another is not able to access facility-based care. Julian, would you add anything just in terms of, as you reflect on your partnership with payers and what you'd call out that's been a real accelerant?
Well, thinking about those patients who are very medically and very socially complex, they can't make it to clinic. I have some of those patients on my own panel, and I understand, Ankara's model, which is let's just go to them. That's the simplest solution. We are very heavily brick and mortar based, but we have people who go to the patients, and so we can do physical therapy and occupational therapy. We have patients in-house or human resources in-house that can go to people's houses and get them set up for that through our own home health service. we have an office upstairs called Care Management who specializes in medically and socially complicated patients. And those are both Medicare and Medicaid patients. They have to have a specific designation in their insurance, and they have to have a specific designation by the state of Washington. And so the state of Washington Department of Health does track patients who are high utilizers of care, mostly from the emergency room standpoint. Okay, if they come through the emergency room, they get admitted to the emergency room. If they're well enough to go home after treatment, they go home, right? It still counts. If you come to the emergency room and get admitted to the hospital, that's still an emergency admission, and so it still counts. So that's really the sweet spot to find out how many people are decompensating or failing in their chronic disease management. And so those patients who have been in the emergency room a certain number of times now make this list. And that list goes out to all the PCPs, which are the primary care providers, and all the clinics that serve them. And so what we did is we participated in a grant through the Department of Health to manage those patients more proactively by having people who go to their homes. They are essentially community health workers who case manage them. They will go with them to patient visits. They will actually be there in person with the patient in front of the doctor and make sure that all the important points are dealt with during the visit. Because these patients, even if they make it in front of you, sometimes they just don't have the wherewithal to explain their needs. If their diabetes has been out of control for so long, they're foggy. They can't think straight. If they're demented, good luck. Have a family member come in there, and the family members tend to, maybe drop in and see them once a week. Maybe they don't live with their mom who's in the nursing home, or their mom's refuses to go to a nursing home, and so she's living independently. With an awful lot of people coming and going trying to help her out. So these are the kind of folks that make that list. We proactively manage them with those community health workers through our care management department. That would be our version of going to the of managing those particular populations. I think the original question was a little bit different than that, though. Chris, what was the original question?
I think we've nailed it, though. Yeah, no, I think we're good. So I think we're at a good point to wrap up now, Julian. So one really quick item, and then I just want to thank everyone. But Simone also requested access to some of the statistics that you mentioned earlier in the conversation, and I think if she goes to the CMAR website, that she may be able to access your annual report. But if that's not the case, Julian, maybe what I'll ask is that you share a link to your annual report with the AHIP team, and then we can make sure that that's able to be accessed. There it is, beautiful. Okay, so thank you, Simone. So thank you very much to everyone for taking time, especially toward the end of the year here, to join Julian and I for this conversation. I hope that you were able to extract a few solid observations and learnings, and appreciate your engagement. And Julian, thank you so much for taking the time to join me. And I'm just incredibly proud and admire the great care model that you and the team at CMAR have developed over the last 50 years. And I think it's a real, again, guiding light in terms of what a highly coordinated advanced primary care model can accomplish in terms of population health, especially for those who are most in need. So thank you again.
Thank you. Thank you, Chris. Appreciate that.
Thanks, everybody.
All right.
I'll hand it
Happy
back
holidays,
to
everybody.
Lisa.
To our speakers, thank you for that great presentation and for sharing your thoughts. And thank you to the audience for participating in today's webinar. This concludes today's presentation. Thank you again, and enjoy the rest of your day.
Bye-bye.